Hello, my name is David Bishop, and today I'm going to be taking you through intubation and some tips on getting it right, particularly in the district setting or the rural setting. So it's aimed at beginner intubators and people just embarking on this journey. Some of the key things you need to do is first assess your patient adequately, prepare adequately, and have a plan B. Think through, what am I going to do if I can't mask ventilate or intubate this patient, and what other options do I have? And it's very important to think about these things before you start, because once everything's underway, it's very difficult to think clearly. In particular, you need to remember to have a supraglottic airway device available. This is probably your standard bailout strategy, and you should have one of these on your airway trolley before you begin. Positioning is absolutely critical, which I'll come to. Maximizing oxygenation, and these techniques just buy you time, and then they prevent panic and hurry when you're trying to insert the tube. And then finally, technique, and I'm going to take you through a stepwise approach for beginners and some of the things that I think beginners sometimes forget or get wrong, and just take you through a simple technique to get you started. When you're evaluating patients, it's important to think about patients in two different areas. The first is, what is the indication for the intubation, and how is my patient globally? And that really impacts how difficult or easy the airway will be. And secondly, a specific or a focused airway assessment. So in terms of the global perspective on the patient, is the patient on oxygen? Hypoxemic patients desaturate very quickly, and it means that you have to work very, very fast. Your technique has to be good, and as a beginner, this can be a highly stressful situation. So when you are intubating patients who are already on oxygen, it's worthwhile having senior people in the room, or at least two pairs of hands, so that the things that you need come quickly to you. Hemodynamic instability is another very challenging problem that when you're managing airways, it can be very, very difficult, because you're giving hemodynamic drugs that affect the hemodynamic status. So blood pressures will drop generally as you give an induction agent, and then you're often not only trying to manage the airway, but you're in a peri-arrest situation, and you're trying to coordinate a resuscitation and airway management. So those patients can be difficult. And then both pregnant and obese patients have anatomical and physiological changes that make their airways difficult. So they might be hard to mask ventilate, laryngoscopy can be challenging, and then they also desaturate very quickly because of their reduced functional residual capacity. And finally, be aware of the patients who are at extremes of ages. Drugs work differently in this group of patients. Often pediatric patients require more drug, elderly patients require less. They've got physiological changes and anatomical changes which might make their airways more difficult, and it's important to regard them as a risk category when managing the airway. And when you come to do the focused airway assessment, there's basically three questions that you're asking every time you evaluate an airway. The first is, will I be able to do mask ventilation on this patient successfully? And because it's an airway area or an emergency area, we have to have acronyms to help us remember, and this one is BONES. The second question you must ask is, will I be able to perform laryngoscopy successfully? And the acronym is LEMON. And finally, will I be able to insert a rescue airway? And that's front of neck access, and the acronym for that is SHORT. And essentially, all these three areas you must evaluate every time you do an airway assessment. And if 2 out of 3 are predicting difficulty, then you have yourself a predicted difficult airway, and you must set up accordingly. So just to run through those, for mask ventilation, the acronym is BONES, and it's worth doing this one. I do this in every patient that I anesthetize. Do they have a beard? Are they obese? And by that I mean, is their BMI more than 26? So perhaps overweight would be a better word. Do they have no teeth? Are they elderly? And again, elderly, the threshold is lower than you might expect. It's just an age more than 55. And do they snore, or do they have obstructive sleep apnea? And difficult mask ventilation is defined as requiring 2 operators. So you're using both your hands to get a seal and to lift up the jaw, and the other person is doing the bag mask ventilation. And it's actually not that common to have difficult mask ventilation. The incidence is somewhere between 1 and 15%, but it's worth assessing because it will remind you to have that experienced second person with you when you do mask ventilation. Prediction of laryngoscopy, again, we use the LEMON acronym. The L just stands for look externally, so evaluate just as you're looking at the patient, and then evaluate specifically mouth opening, which needs to be at least 5 centimeters, and the thyromental distance, which needs to be at least 6. And the thyromental distance I find one of the most useful predictors. So get into the habit of looking at that in every single patient. It tells you how anterior the airway will be. And anterior airways are very, very difficult to manage. So look at the thyromental distance in every patient. Assess Mallampati scores. This is useful for 2 reasons. The one is that it will help you predict difficult laryngoscopy. The second is that it forces you to evaluate mouth opening, and you often look at the teeth at that phase. So it's a useful test to do. Just to remind you, that's how we evaluate the Mallampati score. In class 1 and class 2, you can see most of the uvula. It's class 3 where you can only see the base of the uvula, or class 4 where you can only see the hard palate. Those are the ones that are going to be predicted difficult airways. Just to carry on, you should look for obstruction, and that's often to listen for obstruction. So stridulous patients are much more difficult airways. And finally, look at neck mobility. You're particularly interested in can they extend the neck. And sometimes when you ask patients to do this, they're able to extend the neck, but then they have a bun, and when they're lying on their back, they're not able to extend their neck. So look for reasons that are going to hinder extension of the neck. And finally, look at your ability to insert a rescue airway, and by this I mean a cricothyroidotomy. And the best way to do this is just to feel the landmarks in the neck. So examine the patient and say, can I find the cricothyroid membrane? There is a mnemonic for it. It's called SHORT, and it talks about previous surgery, hematoma, is it an obese patient, radiation or tumors in the area. But I find actually the most practical way to do this is just to feel the cricothyroid membrane and say, will I be able to find that when I'm panicking a little? Prepare adequately, so go and do a proper airway trolley check. That's 5 metals and 5 plastics, and draw up your emergency drugs. Both talks are on the YouTube channel, and they've both been done by Dr. Garth Horston, who does them very, very well. So go and revise on these if you need revision for them. And then if you want some of these aspects in more detail, we've covered them in obstetric GAs, intubation to ventilation, and also an excellent talk by Dr. John Mark Tomlinson on the obstetric airway bundle will run you through some of the things that will improve your success rate and prevent desaturation. Again, before you start, optimize position, maximize your pre-oxygenation techniques, which I'm going to go into in more detail. And remember the RSI adaptation. So during a rapid sequence induction, the things that you're allowed to let go of. And remember that you should have a low threshold for a supraglottic airway device insertion if you're failing. Positioning is absolutely critical. If you look at a patient who's lying flat like this, there are actually 3 axes in the airway that you need to manipulate. Now, the oral, the pharyngeal, and the laryngeal. But really, the point is that if you open the mouth now, you'll be looking down from above. The airway is running at right angles to that view, and so you're trying to look around the corner, and you need to make that a better view. So we position patients in this position. The head is slightly extended, the head is forward in what we call the sniffing position, and you can see the mastoid process is in line with the sternum, and that's what you're aiming for, so that when you look into the airway, that angle is going to enable you to see the vocal cords much better. If you lift the epiglottis, you will see the vocal cords. And you need to position the patient adequately before you start, not after the event. Another way to do it is to just use the operating table. If you have one that allows for this, you can ramp the bed up and then break the head of the bed back. You get the same position. And again, it's that the use of that table will give you the same sort of sniffing position with a slightly extended neck. This is a lateral x-ray of the neck which shows what that position does. So you can see where the eye would look through the mouth with that red arrow, You'll be looking, if you lift that epiglottis up, you can see down the trachea. And that's what you're aiming for, and that's from a website called the Airway Jedi. And there's an anaesthetist there who runs you through simple airway techniques very, very well. I like that site very much. So when you're looking at oxygenation, there are a number of methods that you can use. The two that are most commonly available for you in a district hospital are, on this side, focus on a tight-fitting mask, pre-oxygenate for 3 to 4 minutes. Ideally watch your end tidal oxygenation levels, and you want to aim for a higher than 0.9 or better than 90%. And that'll buy you a lot of time once the patient stops breathing. If you can, add nasal prongs, and this will give you apneic insufflation. The idea being that the oxygen is running while you've got the tight-fitting mask, you've removed it, and while you're inserting laryngoscopes and looking for views, there's actually oxygen running in the background, which prolongs the time to desaturation. And I run that at 5 liters per minute, and then once the patient's asleep, I crank that up to as high as it will go, which is usually 15 liters per minute. But when they're awake, that's a bit uncomfortable. So I start at 5 and I go to 15 liters per minute. Remember 2 things about the rapid sequence induction modifications. The one is that you can release cricoid pressure if that's preventing you from inserting a tube or giving you a bad view. And the second is that once you've given your induction agents and the patient's now gone to sleep but is not yet paralyzed, you can gently mask ventilate these patients. And we call that gentilation or gentle mask ventilation. You keep the pressures below 20 centimeters of water and you just mask ventilate them while you're waiting to be able to insert the tube. And this is an excellent technique for 2 reasons. The one is that it prevents desaturation. So when you eventually get to the intubation, you've got time. The second thing it does is it gives you that reassurance that if I can't get the tube in, at least I can mask ventilate. So it reassures you and it makes everything much, much calmer. So I do this in virtually every patient that I intubate. So now I'm going to run you through a stepwise approach to intubation. And the important part of this technique is that you mustn't progress to the next step until you've accomplished the step that you're on. One of the things that beginners do is they want to get the blade in, and then they just start lifting the blade to see if they can see the cords. And they're in a hurry, and because they don't adequately achieve the goals of the step before, they don't end up having the blade in the correct position. And positioning of the blade is incredibly important. So the first thing that you do is that you're going to aim to insert the blade. And I'm suggesting that you start with a curved blade, sometimes called a C blade, or a Macintosh blade. And this blade is slightly more forgiving of an imperfect position. So you're going to open the mouth, put the blade in, avoiding dental damage and avoiding damage to the lips. So you start putting the blade in. The next thing you need to do is sweep the tongue to the left. So that blade needs to come on the right hand side of the tongue, and the tongue must be on the left hand side of the blade and not sticking out to the right of the blade, which will obstruct your view. Very important step, and before you start doing anything else, make sure the tongue's in the right position. Then you advance the blade forward, looking for the epiglottis. This is a step which people forget. I think they put the blade in on the tongue and they just start lifting up to see if they can see the cords. You're not looking for the cords, you're looking for the epiglottis. Find the epiglottis and then make sure your tip position is right at the base of the epiglottis. Tip position is absolutely critical, especially with difficult airways. So don't start lifting up the laryngoscope until that tip is flush at the base of the epiglottis. And I'm going to show you this on a video just now. And then, only then, do you have permission to lift up, up, and away. And you lift up towards the far corner of the room. It's a straight action and you don't rotate your wrist. Again, I'm going to show you a diagram that shows you this a little better. And consider, once you've lifted up and away, using a burp maneuver. So just to go through those last 2 steps in a little more detail, you're lifting in that plane where that arrow is going up, up, and away. So it's away from the patient, and actually if you do this correctly, you can use a fair amount of force without damaging a patient. You can actually lift the head off the table, and that will give you a very nice airway view. But you must lift up and away. Don't rotate your wrist, don't flex your wrist. That's how you do dental damage. And actually, even though you're lifting up the epiglottis when you do that, you're obscuring your view. So get your tip in the right position and lift up, up, and away. So you can use a burp maneuver. Burp stands for backward, upward, rightward pressure. So you push the larynx backward on the patient to the patient's right. Remember that you're looking on a laryngoscope, and on the you've moved the tongue to the left and you're looking down the right of the airway. So you're pushing the airway towards the right. So it's backward, upward, and rightward, and with pressure. And that'll bring the vocal cords into view. Sometimes what I do is I use my left hand on the laryngoscope, and I will do that myself, and then I'll ask the assistant just to hold the larynx in the position that I've now got it in. And that's very, very helpful. So a view that looks like this, you can just see the opening that you're looking for at the top of this picture. With a bit of burp pressure, you can see we've got a much nicer view. So this is a very good technique once your laryngoscope's in the right position. So now we've finished with lifting up and away and burp maneuvers. The last thing to remind you to do is that you should watch the tube go through the cords. So quite often what happens is you see the cords nicely, you bring the tube forward, and because you're not coming from the side of the mouth, you're coming directly down the blade, you lose sight of the vocal cords. And wherever possible, try not to obscure your own vision of the vocal cords. Watch the tube go through the cords. If you think it's in, check with your laryngoscope that it's gone through the cords. Because if you lose that view, often what happens is it hits the arytenoid cartilages at the base and it slips below the cords into the esophagus. So watch it continually going through and watch that you've got your depth right. Make sure you identify the anatomy well when you're inserting the laryngoscope blade. This is actually a view of the esophagus, and sometimes if you pull on the laryngoscope blade, you can tent the esophagus and they can look a bit like cords. And so people will put a tube down this hole, which is the incorrect one, and that's what you're looking for. And it's not always easy to distinguish the two, but if you've been pedantic about where you stick your tip and how you lift, it should be a little easier. I'm now going to take you through a video of somebody intubating, and just to show these points, and I'll stop it at various points as we go through. So here's somebody inserting the blade into the mouth. They're going down the tongue, not really a great tongue sweep, and they're looking for the epiglottis. There it is, the tip of the epiglottis. Now they've got to get that tip flush with the epiglottis. And so this person is busy looking for that. They're trying to insert it there at the base in the vallecula, looking for it. That's not a bad position, but you'll see the intubator now pushes too far and then pulls it back again. Now we've got a better position, and they're holding that there. There's the vocal cords, there's the glottis. And going too far is a common beginner error. You've got to come back, find the epiglottis. You then lift it up, bring the endotracheal tube, and under vision, watch it go through the cords. Again, when you're a bit nervous, you'll always push the tube too deep. This is what this person has done. They've realized now this tube's too deep, and they're bringing it back, and they're looking for that line. There it is, to tell them have they pushed the tube too deep. Ideally, you do this under vision and not based on the line, but that's a nice catch when you find yourself pushing the tube too deep. The second thing that you want to learn to use is the bougie, the gum elastic bougie. And if I'm in a district hospital, this is my go-to airway device. It's easy to learn to use, and it'll get you out of a lot of trouble. Sometimes where you can't get the tube to where you need it to be, and sometimes where you can only see the epiglottis. And the key to learning to use the bougie well is to do it on easy intubation. So learn the technique, teach your assistants well, and then when you get good at it, when you can only see the epiglottis, you can sometimes insert the bougie behind the epiglottis, feel it go into the trachea, and you feel the tracheal rings as you advance it. You feel the bougie stop because you're in the lung. If you go into the stomach, it never stops, it just keeps going. And then you railroad a tube over the bougie. And in this video, I'm going to show you this gentleman does that, and then I'm going to show you another tip with the bougie. So here he is, he's got his laryngoscope blade in. Now just to pause it there, you see the assistant has been primed. Once his laryngoscope blade is in, you can see him pulling quite hard because he's working on a mannequin up into the far side of the room. He's going to insert that bougie that's been handed to him by the assistant. Let's watch him do that. That's in now. Now the assistant has to load the endotracheal tube onto that bougie. The person who's intubating hangs onto the bougie while that tube gets loaded, and that tube should get loaded until the tip of the bougie is sticking out the end, which these guys don't do perfectly. Here it comes, it goes over the tube. Now the assistant grabs the end of the bougie and the intubator advances the tube into the airway. Importantly, look at the left hand of the intubator. He hasn't released that laryngoscope. So it's a common error is that you lift up the epiglottis, you put the bougie through the airway and you think great, and out comes the laryngoscope handle. You won't be able to advance the tube as easily if you've taken the laryngoscope out. So leave the laryngoscope in, lifting up the epiglottis, and then only once that tube is in, and he's going to force it in now, pushes it a bit deep, and then he's going to remove the laryngoscope and the bougie and check it. Alright. Another tip that this clip shows you is that sometimes when you're pushing that tube over the bougie or the introducer that you're using, you find it sticks on the vocal cords. And the trick to getting it in at that point is to rotate the tube anti-clockwise. So here he is demonstrating exactly that. As he goes down, he turns it, watch him swivel it with his fingers over anti-clockwise. Only now the laryngoscope comes out and the bougie comes out. And that's a very useful trick. I do it almost every single time I use the bougie. So that's some basic tips. It's a basic intubation techniques that you can use. This is a website called Open Airway. It's a South African website, openairway.org, which is administered by Professor Ross Hofmeyr. There's Ross there. You can tell he's an airway guru because he's busy doing an awake fiber optic on himself, which seems to be the way that you recognize airway guys. He's got a number of really nice resources on this website. If you go to the website, you'll find there's an airway web resources where he points you to a number of other websites which are full of good videos and good content and educational videos. But even on his own website, there are a number of videos that will take you through basic and advanced techniques. And really, there's everything you need to know if you want to go into a little bit more depth. And I've just provided a very simple beginning or introductory lecture. This is the next step if you're interested. Thanks very much.